aid will do it for the exam but not for the EEG, and hypnosedative drug intoxication. Right. So the EEG is not a very useful screen for this because you can tell from the pupils that it's a neuromuscular junction problem. And then they said that they picked 32 as a temperature, which is close to what we do now. And they said everything has to be repeated in 24 hours without any change. And if there's one difference now versus a year ago in the published guidelines, it's we've finally eliminated this 24-hour thing after 40 years of wasted time. The Minnesota criteria came next. They said there should be a 4-minute apnea test. And they list a whole bunch of things, including the ciliospinal reflex, which is the one reflex related to the head that doesn't involve the brainstem. So painful stimuli on the side of the neck will produce a sympathetic outflow from the superior cervical ganglion and dilate the pupil without going through the brainstem. So that's a ciliospinal reflex, and it is compatible with being dead. The NDS collaborative study took 500 comatose and apneic patients, and here they had to be apneic for 15 minutes. So if they weren't dead before, they sure were then. And said that if you were unresponsive, apneic with dilated pupils, no reflexes related to the face, and a flat EEG for at least 6 hours after your arrest or whatever the cause of death was, then you were really dead. Well, then Alan Schumann, and the other part of this, by the way, was they said that no matter how hard you supported somebody, the body was going to die in 72 hours. And that was nice to quote, except Alan Schumann came out with this study where he found what he thought were at least 56 patients who had bodies survived for years when the brain was dead. Right? So you can't use the argument that they'll all be somatically dead in 72 hours. It's not always true. So how should we go about diagnosing this? Well, the first thing is you need a permissive diagnosis, meaning there has to be a reason why this person would be dead. How do you diagnose that? Well, often you get a scan. You show that there's been a huge intracerebral hemorrhage, or there's been trauma, or there was a cardiac arrest without return of spontaneous circulation for an hour, and now you've got a pulse back, but you have no brain function. You need to exclude hypothermia and drug intoxication, and you need to show that there's intact neuromuscular transmission. I was once called by the chief of cardiac surgery to pronounce one of his patients dead after resuscitation so that her organs could be taken. Well, she'd received pancuronium in the midst of the arrest and a lot of atropine, but it was quite clear that she was awake because the pancuronium had worn off just enough for her to have a little bit of eye movement. Right? So not only was she not dead, she heard everything that was being said at the bedside. So luckily we salvaged her from that. But you want to show that neuromuscular transmission is intact. Typically you can just show that they have reflexes. If they have reflexes, then the neuromuscular junction's working. If you're not sure, then get out the train of 4 and make sure they have 4 contractions. There can be confusing things. So the Guillain-Barré syndrome is actually the one that will produce everything on exam, including loss of pupillary function on rare occasions. And so in this person, you don't have a permissive diagnosis. You have an exam that looks like they're dead, but you don't have a reason for them to be dead. I've had a few people like this, and you need EEG monitoring to see whether they're alive or not. So the point here is if you don't have a reason for that, why this person would be dead, then you can't proceed, certainly without some sort of confirmatory test, and we'll talk about that at the end. So you want to show absence of brainstem reflexes. We'll talk about how you test eye movements in just a second. No cough, no gag, no corneal reflexes, no pupillary reflex, and no response to noxious stimuli applied to the face. Now in England, they don't even try applying noxious stimuli to the rest of the body. It's not part of their protocol. They're looking to diagnose brain stem death. They're very clear about it, and I think it's actually a very useful way to approach this. Pupillary responses start out at the retina. They become bilateral at the level of the optic chiasm, and the information coming back out to each eye should be equal. And it's the sum of the light information getting into the two eyes. The pupillary dilation response actually starts up here in the hypothalamus and has to descend into the thoracic cord before it comes out and gets back out to the eye. So if we try to superimpose where these problems would be, if you have trouble in the hypothalamus or you have a drug overdose, and almost all drug overdoses affect the hypothalamus more than the rest of the brain, those are people who have small pupils. They're reactive. If you put more light in the eye, they'll constrict more. If you have a problem in the back of the brainstem here, you'll knock out those constricting fibers in the parasympathetic system without affecting the dilators that run through the middle. So those pupils will be on the large side. They're fixed in that they don't respond to light, but they may show hippus, which is spontaneous 1 or 2 millimeter fluctuation in diameter. And if we went around this room and turned the lights down, we'd find several people who have hippus as a normal phenomenon. If you have compression of the third nerve, you lose the efferents on one side, so then you get a large pupil on that side. If you have a problem that affects the whole midbrain, you lose the sympathetics coming down and the parasympathetics moving forward, so you can't dilate or constrict. You have mid-position, unreactive pupils that don't respond to light. And if you have a lesion in the pons that's large, like a pontine hemorrhage, you still have the parasympathetics, but the sympathetics are lost, so these pupils are small. If you shine light in them, they'll still constrict even more. So if you go to see a comatose patient with pupils like that, the diagnosis is narcotic overdose 99 times out of 100. 1 time out of 100 it'll be the pontine hemorrhage. But again, this just tells you that there's no sympathetic tone coming out. This tells you no parasympathetic tone. This tells you no tone at all. So the lateral eye movements depend on coordinating structures within the midbrain and the pons. I guess I should turn off this animation. All right, so let's say that the person is unresponsive and we want to see whether the brainstem works. We'll pull the eyelids open and watch. And in the lightest levels of coma, if you will, you open the eyes and you see that you have horizontal conjugate eye movements that go fully from left to right. You're really done with your exam there. You know that the brainstem is working, that the problem is bilateral hemispherical dysfunction. It can't be anything else. The issue then, though, is you open the eyes and the eyes are just sitting there. How do you get them to move? Well, if you're not worried about the cervical spine, you can turn the head to one side or the other. If you turn the head to the right and the brainstem is working, the eyes should go to the left. That's what was described at the turn of the last century as the doll's head or doll's eye response. So if you say doll's eyes are positive, it means you turn the head to the right, the eyes go to the left. You turn the head to the left, the eyes go to the right. But if you took a poll of neurologists, you wouldn't get a consistent answer. So I would stay away from that term. This is a cervico-ocular reflex. It's either present, absent, or it's partial or abnormal. Again, if the eyes move conjugately in both directions, you know that the brainstem is intact. And the part of the reticular formation we're worried about is sitting right in here. And that's why I can say with such confidence that it either is or isn't the brainstem at fault just by looking at these eye movements. If I don't get any eye movements when I turn the head or I'm worried about the cervical spine, then I can put cold water in the ear. That sets up a convection current in the semicircular canal that will again produce the same sort of eye movements. Right? So don't say doll's eyes because nobody will know what you mean. But all these tests are designed to see whether the spine works. That's just a summary from Plum and Posner. I'm sure whether the brainstem works. Respiratory patterns we already covered. Posturing, if both arms flex, which is a better way of describing this than saying decorticate rigidity because nobody can quite remember what decorticate is. All right. If they flex, that means that you've lost the hemispheres, but the red nucleus is still intact. If they extend, it means you've lost the red nucleus, but the vestibular nuclei are intact. And if the arms don't do anything but the legs flex, now you've lost the vestibular nuclei. All right, now do you need to remember that? No, just remember that when you go from this to that, you're getting worse. If you go from this to that, you're getting better. All right, you can look it up once you find the response. You just have to recognize what you're looking at. There are a variety of spontaneous and reflex movements that have been described in patients who are clearly dead by every criteria. It's important to think about this. This came up for us recently in somebody whose reflex movements like this resembled decerebrate posturing, and we ended up doing an angiogram to prove that, yes, in fact, the patient was dead. So there are a lot of things here. They're worth knowing about. They happen pretty frequently, although many of them are very minor. And in particular, though, there's the Lazarus response where you are doing an apnea test and the person sits up. Right? So flexion at the trunk, which is all mediated by the spinal cord, is the reason why if family members insist on staying during the apnea test, I make sure they're sitting down. And I warn them beforehand that this might happen. I did have a doctor faint during one of these when I saw it. But, a big orthopedic surgeon, of course. All right. How do you do apnea testing? Well, basically, you're trying to give a stimulus of acidosis. And the way that we do this is by making the patient hypercarbic. We really ought to deal with the pH rather than the PCO2. There are many ways to make somebody hypercarbic. The two commonest ones are to pre-oxygenate them and then try to give them oxygen either via CPAP or a tracheal catheter. The CPAP is what I prefer to use, but you can't do it on a modern ventilator because of the apnea modes that will cause a breath. So you need an old-style CPAP stand if you're going to do that. Recently, people have been trying to use carbogen, the higher concentration of CO2 mixed with oxygen, as a way of ventilating somebody but making them hypercarbic. Nobody's really tested this in large numbers, but it seems to work. All right, the last question in this group: which of the following is the least useful confirmatory test for death by neurologic criteria? EEG, transcranial Doppler measurement of cerebral blood flow, CT perfusion scanning, evoked responses, or cerebral angiography. Which is the least useful? And you won't see any of these least questions on an exam anymore. They all have to be positive because as doctors we're too stupid to figure it out. All right, well, I'm with 48% of you. Even though I'm a card-carrying neurophysiologist, this is not a use for the EEG. The reason is, as I mentioned before, the things that make the EEG look flat in somebody who can recover are the same things that make the exam confusing. So hypothermia, hypnosedative drug intoxication. Transcranial Doppler measurement of cerebral blood flow has been accepted as a way of testing death in that you show there's no bulk movement of blood into the brain. It does have a problem. About 20% of people, you don't get a decent window through the temporal bone to examine it. CT perfusion scanning, if there is perfusion, then the person's not dead. The presence of some false positives, meaning lack of perfusion on this test when it's demonstrated elsewhere, has led to this being not widely adopted. Evoked response testing, looking at brainstem evoked responses showing that you have normal conduction into the auditory system but nothing above it, has also been used. I don't care for it, but you could use it. Angiography is the gold standard in a number of countries where you have to do a real contrast angiogram to show no blood flow to prove that the person's dead. But of all these, the worst one is the EEG in terms of... all right. The correct answer, I'm sorry I put this down wrong, the least useful test is the EEG. The most useful test, meaning if you have no blood flow, you are dead, is the angiogram. So I'm sorry for that confusion. Thank you. All right, so you generally don't need confirmatory tests. The most typically used one, if you decide you have to do it because you can't pull the eyelids open, and so therefore you can't examine the eyes. So the patient who went through the windshield may not be examinable. Or the person has gotten a barbiturate for some reason, and although barbiturates that are down in the so-called therapeutic range are said not to confuse your examination, if you wanted to be absolutely sure, you'd either wait for there to be no barbiturate in the blood or you would do something to show that there was no blood flow. Typically, people have used a nuclide angiogram, but if I really want to know, I just use a contrast angiogram. This happens about once every 20 years. I already talked about EEG, so I'm not going to say anything more about that. Finally, last month, the American Academy of Neurology published this update on the 1995 brain death guidelines or death by neurologic criteria guidelines. That's not in your handout because it just came out. But it's worth knowing that it's there. The one thing that is really different from the past is they finally said there's no need for a second exam. All right, that if you did everything right, one exam is enough. All right, I'm going to skip the pediatric part and skip that so we can go on to the next talk.